speaker is Dr. Erik Lewis, his friend and colleague. He's the director of the Mayo Clinic Behavioral and Neurophysiology Lab and professor of neurology there. Erik is a consultant neurologist, board certified in neurology, sleep medicine, as well as in epilepsy. He's really one of the world authority in the field of sleep medicine, especially when it comes down to the overlap between sleep and epilepsy, which is an area that's quite interested in, and he'll be discussing it in the coming 20 minutes, the overlap between sleep and epilepsy. So please, you can start his recording.
Good evening. My name is Erik St. Louis. I'm a neurologist and sleep specialist in the United States at Mayo Clinic in Minnesota. I'd like to thank Dr. Mohammed Al-Kalani for his kind invitation to speak to you this evening. And my topic will be that of sleep and epilepsy, strange bedfellows no more. In this brief talk, I will discuss some of the fascinating and reciprocal relationships between sleep and epilepsy, including how sleep influences epilepsy and the epileptic state. In particular, we'll dig a bit into how sleep may influence the occurrence of interictal epileptiform discharges as well as seizures, how sleep macro and micro architecture influences these phenomena, and we'll examine how seizure phenomena occur in sleep, including some of the prototypical sleep-related epilepsies. We'll also then consider in turn how epilepsy influences the sleep state and how it may shift deeper sleep towards lighter sleep stages that may be less restorative. We'll briefly consider circadian rhythms and their influence on the occurrence of seizures and seizure frequency and periodicity. And we'll conclude with a few pointers on the practical recognition of comorbid sleep disorders in patients with epilepsy, a topic that will have broader application to your encounters with patients in the neurologic clinics throughout the practice of neurology. Because two of the most common comorbidities from the sleep disorder standpoint in neurologic clinics include obstructive sleep apnea syndrome and insomnia. So we'll discuss some pointers on recognizing these disorders and a few aspects of their treatment. To begin with, then, we'll discuss the reciprocal aspects of sleep and epilepsy, starting with how sleep influences the epileptic state. If we consider a model of epilepsy, we can consider that brain dysfunction of some type may cause both seizures, the ictal events, as well as have effects on the interictal state between seizures. This is a diversity of effects and a diversity of comorbidities that play in, including sleep and sleep disorders. So importantly, sleep disorders may cause further disruptive brain dysfunction that may feed back to trigger seizures and aggravate them. As we consider the pathophysiology of sleep-related seizures, we have noted that the physiologic hypersynchronous state of non-rapid eye movement or non-REM sleep may influence the occurrence of both interictal spikes and seizures. It's interesting that lighter stages of non-REM sleep, those being N1 and N2, where sleep spindles are particularly frequent, seem to have a more seizure activating influence. Whereas N3 or slow wave sleep tends to bring out interictal epileptiform discharges or spikes by making them both more frequent and expanding their electrical field of expression. Interestingly, many of you know that N3 or slow wave sleep is involved in consolidation of neural engrams, including perhaps best known, the impact on memory functioning. But interestingly and more controversially perhaps, post-ictal sleep may have the same facilitatory process on seizure engrams and potentially have an effect on the wiring of the epileptic network. Non-REM cyclic alternating pattern microarchitecture, which are oscillating rhythms that may reflect cortical infraslow rhythm activity. These are delta oscillations below the frequency band of 1 Hertz, very slow oscillations that have a time scale of half a minute to a minute or longer. may play a particular role in facilitating this epileptic activity. And it's been shown that of these infraslow oscillations, which represent cortical up and down states in large scale neural assemblies, that these infraslow rhythms may facilitate high frequency oscillations as well as interictal spikes during the upstate or rising phase. When we consider on the other side REM sleep, rapid eye movement sleep, it is a more desynchronized state physiologically and seems to have a role in inhibition of seizures, which can be used to clinical advantage in the sense that during REM sleep, interictal spikes as well as high frequency oscillations become more restricted in their expression and become more focal and have particularly better fidelity to the underlying epileptic focus, a fact that can sometimes inform surgical decision-making. So when we consider the occurrence of seizures during sleep and prototypical sleep-related epilepsies, focal seizures in particular may be more frequent during the sleep state and especially during light non-REM sleep. Seizures tend to be rarer in slow wave or M3 sleep and generally absent in REM sleep, although they may rarely occur there too. Bilateral or generalized tonic-clonic seizures also become more frequent during the sleep state as compared to diurnal seizures, particularly true for temporal lobe epilepsy and temporal lobe seizures, which more frequently propagate during the sleep state as compared to while awake. Seizures also may be longer during slow wave sleep and non-REM sleep than in light sleep or wakefulness. When we consider types of epilepsy that are particularly apt to occur during sleep, frontal and temporal lobe epileptic seizures are particularly likely to be sleep-related, and specific epileptic syndromes such as sleep-related hypermotor epilepsy, formerly known as nocturnal frontal lobe epilepsy, as well as nocturnal temporal lobe epilepsies might be solely seen during the sleep state with no waking seizures at all in some cases. Also, the prototypical childhood epilepsy of benign epilepsy of childhood with central temporal spikes, so-called Beck's or Rolandic epilepsy, has a unique linkage to the sleep state, with sleep-related convulsions or focal motor seizures being the most common expression. Also, arousals might be facilitatory of certain seizure types. This is particularly true of juvenile myoclonic epilepsy, where there are likely both circadian influences as well as the influence of post-arousal, which might serve to trigger seizures and make them more common in the morning hours, particularly true of the myoclonic jerks, as well as bilateral or generalized tonic-clonic seizures. Well, next we'll turn our attention in this reciprocal relationship between sleep and epilepsy to how epilepsy may influence sleep, also considering how treatments for epilepsy impact the sleep state. Epilepsy tends to fragment sleep and may thereby also erode daytime alertness and attentional capacity. There's evidence for this both in adults as well as in children. In the adult, seizures, whether they occur diurnally in the daytime or arise in the nighttime out of sleep, may both have deleterious influences on sleep architecture. It's been shown that daytime seizures in the following night's sleep might reduce REM sleep, whereas nocturnal seizures have a more profound influence, particularly reducing the efficiency of sleep, that is, reducing the time spent asleep versus time in bed. Nocturnal seizures may also reduce REM sleep, as well as deeper restorative N3 or slow wave sleep at expense of also increasing N1 or light sleep. Nocturnal seizures also have been shown to delay the latency to enter REM sleep, and accordingly, these deficiencies of sleep caused by seizures are often then associated with objective excessive daytime sleepiness, as shown on the objective measure of the modified maintenance of wakefulness test. In children with primary generalized epilepsy against controls, it's been shown that the children with epilepsy have increased lighter N1 sleep stages, a longer latency to enter first REM period, similar to adults, and that these sleep deficiencies are correlated with poorer daytime attentional function. When we consider epilepsy therapies and their influence on sleep, it does appear that the epilepsy therapies are double-edged swords. They help seizures, certainly, but they might have some deleterious influence on sleep. Conversely, there are some treatments that may have favorable sleep features, and we'll consider those as well. In terms of those that might be categorized as some unfavorable influences on the sleep state, it's best known that some of the older anti-seizure drugs and one newer one might worsen daytime sleepiness. This includes the drugs phenobarbital, valproic acid, or Depakote, and levetiracetam or Keppra. Drugs that decrease slow-wave sleep, particularly also include ethosuximide and phenytoin, while the benzodiazepines and barbiturates tend to increase N1 and N2 sleep features, or particularly spindles, while decreasing deeper restorative N3 slow-wave sleep and REM sleep. The VNS has mixed effects. First, we'll consider its deleterious effects, and VNS may exacerbate underlying or as yet undiscovered sleep apnea, and rarely may cause sleep stridor. It's felt to do so by activation of pharyngeal constrictors and laryngeal adductors. And many times these are voltage-dependent phenomena or parameter-dependent phenomena more properly, so that change of VNS stimulus parameters may improve some of these features, particularly by reducing signal frequency or pulse width. The SANTI, anterior nuclear thalamic deep brain stimulation modality, has also been shown to mediate some deleterious effects on sleep architecture by increasing microarousal during stimulation phases. Now, conversely, there can be some favorable impacts of some of our anti-seizure treatments. Lamotrigine may increase REM sleep and reduce arousals. Gabapentin and pregabalin, the alpha-2 delta ligand agents, may increase N3 sleep, which has also been seen for the ketogenic diet. Just as VNS may have some negative effects on sleep-disordered breathing, on the whole, it tends to improve alertness when sleep apnea is not present. There has been shown to be improvements in objective sleepiness on the multiple sleep latency test, with increase in sleep latency on that measure during VNS treatment. Surgical resection might also improve sleep architecture and sometimes improves postoperative sleep apnea by improvement of seizure burden. Well, next we'll turn attention to the influence of circadian rhythms and on seizure frequency, occurrence, and seizure periodicity. Of the various epilepsy syndromes, temporal lobe seizures in particular have been shown to have a robust circadian pattern, with a peak in the frequency of occurrence of temporal lobe seizures occurring diurnally during the daytime, particularly in the late afternoon hours, but also sometimes with a bimodal distribution, with a peak of seizure occurrence in the morning hours and accordingly also in the late afternoon and early evening. Extratemporal seizures have variable but predominantly nocturnal and unimodal peak times of occurrence. This includes the frontal and parietal lobe epilepsies and some occipital lobe epilepsies. When considering the primary generalized epilepsies, these tend to have broad waking diurnal peak seizure frequencies of occurrence. And when examining interictal epileptiform discharges, there is no particular circadian pattern to these, but interestingly, recent work has shown a more multi-DN or broader time scale frequency of oscillations of these phenomena over even a 20 or 30-day period, similar to the female menstrual cycle. Seizures may tend to peak during the rising phase of the occurrence of these interictal spikes on a longer time scale. So I think there's much to be discovered still about endogenous brain rhythms, circadian rhythms, and longer scale rhythms that might inform seizure prediction in the future. Well, last, we'll turn our attention to comorbid sleep disorders and epilepsy, and particularly consider the recognition and treatment of obstructive sleep apnea syndrome and of insomnia. And regardless of the population, this data here is from an outpatient epilepsy clinic population. Sleep disturbances tend to be more frequent in patients with epilepsy than community controls, but also more frequent generally than in other neurological patient types. In particular, sleep disturbances that are chronic over the past several month timescale, but also in the previous night were shown to be more frequent in those with focal epilepsy than controls in this paper. We have also turned attention to the frequency of sleep comorbidities in our community dwelling patients with epilepsy in the Olmsted County epidemiologic project. And looking at a cohort here of 104 patients recently in our community, fully half or 49% of these patients had some significant sleep-related comorbidity. Interestingly, about 30% had obstructive sleep apnea, about 15% had chronic insomnia, and about 4%, which is similar to population prevalence, had restless leg syndrome. Importantly, these sleep disturbances may correlate with quality of life impairments. Here we are seeing regression models fitting the quality of life in epilepsy on the y-axis versus two forms of sleep disturbance. The left graph showing the Epworth Sleepiness Scale score, where higher scores tend to indicate greater sleepiness. Whereas on the right, we see the measure of the Pittsburgh Sleep Quality Index, a measure of insomnia and sleep quality. And similar responses are seen where the greater the sleep disturbance, in the case of the ESS, more hypersomnolence. In the case of the PSQI, greater insomnia symptoms, both tend to erode quality of life in patients with epilepsy. In terms of sleep comorbidities in epilepsy, sleep apnea, restless leg syndrome, and insomnia have emerged as probably the big three and ones to look for in your patient populations. People with epilepsy tend to be sleepier than other neurological outpatient populations. And interestingly, as epileptologists, we might think that factors such as nocturnal seizures, epilepsy polytherapy with multiple anti-seizure drugs, or frequent seizures might be the determinants, but instead, comorbid primary sleep disorders tend to be the largest predictors independently for sleepiness in epilepsy patients, particularly obstructive sleep apnea and restless leg syndrome. Obstructive sleep apnea frequency has been variable in epilepsy, but tends to be more frequent in drug-resistant epilepsy populations. Broadly, about 10 to 35% of adult epilepsy patients in various studies have been shown to have this comorbidity. Importantly, moderate sleep apnea, a severity of sleep apnea that has health risk, even without major symptoms, is seen in about 1 in 6 drug-resistant epilepsy patients, and is also seen in about 30 to 44% of children with drug-resistant epilepsy. There have been links to the occurrence of sleep apnea with anti-seizure drug polytherapy in some studies. Restless leg syndrome is another comorbidity, has a variable prevalence, but is seen in about 6 to 35% of adult epilepsy patients. Insomnia appears to be a particularly common sleep comorbidity, seen in between almost 30 and 50% of people with epilepsy, and about 13 to 32% of children with epilepsy. The epilepsy-specific associations with insomnia have included temporal or juvenile myoclonic epilepsy syndromes, the phenomenon of drug-resistant epilepsy in general, or anti-seizure drug polytherapy. Comorbidity associations include comorbid mood state disorders, asthma, or chronic obstructive pulmonary disease. Importantly, I think if you learn nothing else from this talk, I want to emphasize the recognition of sleep apnea, not only in epilepsy, but in broader neurologic populations, whether you work in an epilepsy clinic, a general neurologic practice, or other subspecialty practices. For example, cerebral vascular neurology, behavioral or cognitive neurology, and movement disorders neurology, as well as multiple sclerosis clinics, all are going to be areas where you see a lot of comorbid obstructive sleep apnea, where recognition and treatment of this can greatly improve your patient's quality of life and functioning. One might screen for obstructive sleep apnea syndrome using the STOP-BANG questionnaire. STOP-BANG is the English acronym, stands for various demographic and anthropomorphic features that may predict sleep apnea. The STOP stands for S for loud disruptive snoring, T for tiredness, particularly using the screening tool of the Epworth Sleepiness Scale, where a score greater than 10 tends to indicate a significant sleep comorbidity causing sleepiness. Obstructive apneas during sleep being witnessed, and a pressure, that is blood pressure, too high, are features historically that tend to go with sleep apnea. The BANG of STOP-BANG stands for more physical features, and here a body mass index over 35 kilogram per meter squared, age over 50, neck circumference thicker than 40 centimeters, or male gender are factors that may portend sleep apnea. Now, high-risk patients tend to have 3 or more positive items out of this 8-point scale. You might consider the patient lower risk if they have less than 3 items positive. For the Friedman score, an inspection of the oral pharynx, the more narrow the oral pharynx, as you can see in the drawing on the right, the greater the risk of predisposing anatomy to obstructive sleep apnea. And whether you use the Friedman score, which is with the palate relaxed, or the Mallampati, the theme is that higher scores of 3 or 4 tend to portend a narrow and predisposing anatomy to sleep apnea. So look for these physical features in your office, and I think you'll find they help you identify patients highly likely to have this important sleep comorbidity. Additionally, one can screen with a portable overnight oximetry device. These devices are now widely available. And when we did so in our epilepsy monitoring unit population, we found that 1/3 of patients had probable obstructive sleep apnea identified on their sleep oximeter, not all with typical symptoms of sleep apnea. You can see oximeter traces. On the left is a normal example. On the right, and with red circles, are clustered oscillatory desaturations typical of sleep apnea comorbidity. Of our patients, about 29% had drug-resistant epilepsy. So again, there's a theme that these patients might be more likely to be predisposed. And the mean oxygen desaturation index in our population was 11, which is starting to get into the upper mild to approaching moderate range of sleep apnea severity. Predictors for probable sleep apnea included older age and heavier body weight, and higher screening scores on apnea predictive scores, including the STOP-BANG score that we shared with you. Interestingly, when we looked at the oximetric oxygen desaturation index, this appeared to be a potential strong association with the SUDEP-7 index score, suggesting that sleep apnea, in addition to being a disruptive comorbidity in these patients, could even potentially place patients at greater risk for sudden death. Importantly, treatment of sleep apnea may make a big difference in their seizure burden and actually be the forgotten anti-seizure medication. In a prospective sham-controlled study, which was a pilot study not intended to definitively answer this question, patients had a nice response rate. In a variety of retrospective studies where it's certainly lower quality evidence, but I think representative of the experience we see, the odds ratio for seizure freedom with CPAP treatment was 1.5, and in compliant patients, even a bit better. Another retrospective study found that CPAP-treated patients, when looking with similar lens as we do in an anti-seizure medication trial, considering the response rate, which is the percentage of patients with a 50% or greater seizure reduction, about 74% were responders, which is a robust response rate with about a 59% median seizure reduction. Now, insomnia is another important sleep-related comorbidity in these patients. Insomnia is not difficult to recognize. It typically is difficulty initiating or maintaining sleep on a chronic persistent basis. Cognitive behavioral therapy, which involves a combination of cognitive and behavioral therapies, is considered the first line approach for insomnia, including sleep hygiene counseling, and importantly, sleep restriction by limiting the time in bed. Zolpidem or the Z drug hypnotics are generally safe and effective. They're not particularly recommended for long-term use, but a caution may be with chronic use that with withdrawal seizures might be possible. Melatonin has been studied particularly in children and found to have at least modest effect in reducing sleep latency and wake after sleep onset time. And pregabalin or Lyrica dosed twice daily has been shown to improve objective polysomnographic measures in patients with focal epilepsy, increasing sleep efficiency as well as N3 sleep and decreasing lighter sleep and improving tension. Interestingly, you might worry that sleep deprivation always worsens epilepsy, and the evidence here is mixed. While there does appear to be biological effects of sleep deprivation, particularly with REM sleep deprivation and increasing cortical excitability by transcranial magnetic stimulation studies, in broader studies involving sleep diaries or sleep deprivation in an epilepsy monitoring unit study, in fact, sleep deprivation, as much as we worry about it, did not appear to substantially impact seizure frequency. Nonetheless, we still typically coach patients to try to adhere to a good sleep schedule and regularly get adequate sleep quantity. Well, in conclusion, it's been my pleasure to speak to you. Sleep state and circadian biology both influence the occurrence of seizures, the seizure type, and periodicity. Non-REM sleep tends to facilitate, while REM sleep tends to inhibit both interictal spikes and seizures. The limbic and temporal lobe epilepsies tend to be seen most with pattern of day being during the daytime, whereas the neocortical, frontal, and parietal lobe epilepsies, some occipitals, are more apt to peak in nocturnal hours. Seizures, as well as their treatments, may also in turn disrupt sleep, tending to shift sleep from a deeper, more restorative type to a lighter and less restorative type of sleep that sometimes impairs daytime functioning. Importantly, I also want to leave you with the message that drug-resistant epilepsy patients commonly harbor sleep comorbidities that may benefit from recognition and treatment and improve patient quality of life, particularly obstructive sleep apnea syndrome and insomnia. So I thank you very much for your attention. We'll welcome any questions during the Q&A or at the email shown. Thank you very much, and I hope you enjoy the rest of your meeting. Best wishes to you all to stay well.